So hematomas and brain bleeds are probably one of the leading causes of increased intracranial pressure. And as we said, these can lead to, this mass effect can lead to brain herniations, local neurodeficits. And if we want to reduce this pressure, we're going to want to treat this with diuretics to reduce the amount of liquid in the body, a cerebrospinal fluid shunt, a lumbar puncture to relieve pressure, and you could potentially remove parts of the skull as well. When people do have elevated intracranial pressure, they're going to have papilledema. So papilledema here, we're going to see the optic disc, the radius, the margins kind of expanded and blurred a little bit. So this is going to be associated with vision issues. And the optic disc, there's actually no cones and rods there, so that's a blind spot. So you're going to have an enlarged blind spot. Elevated intracranial pressure is also going to be associated with things like headache, seizure, nausea, and vomiting. So cerebral perfusion pressure is how much pressure we need to adequately perfuse the brain. And it's going to be equal to the arterial pressure minus the intracranial pressure. So if we think about this over here, let's imagine that we have just the perfect cerebral perfusion pressure. Okay, well, then what if I then get shot and I start losing a lot of blood? My arterial pressure goes down, and it might go down enough that I cannot adequately perfuse the brain anymore. And we talked about this earlier with like watershed regions. So that's one way you could have a decrease in cerebral perfusion pressure. But another one relevant to this section is that if we have an elevated intracranial pressure, it might be difficult to adequately perfuse the brain unless there's a concomitant increase in the mean arterial pressure. Another thing to note about this is the idea of autoregulation in the brain. So let's imagine that we have the perfect cerebral perfusion pressure, but you start smoking and you're not exercising, you're eating a lot of bad food, and you're stressed, and just chronic hypertension. Your MAP just starts getting higher and higher and higher and higher. Well, if your MAP gets higher, then you know what? So is your cerebral perfusion pressure. So it's going to get higher and higher and higher and higher and higher. But why am I not getting more cerebral blood flow? Well, keep in mind, we don't want more cerebral blood flow. That would be a bad thing. But your body is going to respond by constricting these blood vessels. So yeah, we're getting a larger perfusion pressure, but because we have smaller blood vessels, less volume to allow less blood in, it actually kind of offsets the effect of increased cerebral perfusion pressure. So at the end of the day, the most important thing is we have a continuous stable blood flow, not too much, not too little, until at a certain point our blood pressure is too high and we just can't auto-regulate anymore, and then it's just going to zoom up and might even snap and pop these vessels open. On the other hand, if I get shot and I'm losing too much blood pressure, my vessels can only open so much, and my blood flow is going to go to nil. Something called Cushing reflex when we have increased intracranial pressure, and I like to think of it as like a 1, 2, 3, and then also 1, 2. They're separate. So I have a tumor, I have hemorrhage, hydrocephalus, which we'll get to, increased intracranial pressure. We just saw that if the intracranial pressure goes up, then the MAP needs to go up too. So your body is going to constrict, arterial vessels and maybe dilate cerebral vessels. But let's just focus on the constricting of arterial vessels. Hypertension, the MAP is going to go up to match this increased ICP. Well, then the carotid and aortic receptors are going to tell cranial nerves 9 and 10 that, hey, like there's some weird hypertension, like maybe we shouldn't, pump so hard. And so you're going to get bradycardia. This is at least how I think of it, right? So increased intracranial pressure needs to be matched by increased MAP, so we have adequate CPP, and then the hypertension, naturally your receptors are going to respond by inducing parasympathetic stimulation of the heart to induce bradycardia. Now, as far as the irregular breathing, so this is a separate now 1 to 2, 1 to 2B. Increased intracranial pressure is going to push down on the brainstem. The brainstem has, cranial nerves 9, cranial nerves 10, a lot of components that are necessary for maintaining a normal respiratory rate. So that is why the breathing gets altered. So one way you can get increased intracranial pressure, and really not a way, it's idiopathic, they're not really exactly sure how it works, is something called pseudotumor cerebri. And it's going to be a middle-aged woman, young to middle-aged. She's going to be overweight. She has a vitamin A excess, and she is taking tetracyclines, probably for acne, and for whatever reason they have increased intracranial pressure. And this is going to come with all of the things that we've associated with it. Things like nausea, vomiting, headache, right? All of those things that naturally go with increased intracranial pressure. So increased intracranial pressure, just in general how you get it, could be something like a mass, but it could also be that we're putting too much blood into the system and taking too little out, or putting too much CSF into the system or taking too much CSF out. An example is like a venous thrombosis. If someone's in a hypercoagulable state, they get a venous thrombosis. More blood is going in that can go out, and this could lead to increased intracranial pressure. What's relevant for right now is hydrocephalus. So increased intracranial pressure because we have too much CSF in the brain. And there's kind of like 4 different ways that we can think of hydrocephalus. Non-communicating. So communicating means sharing. So this is not sharing. What does that mean, sharing? It means not sharing is that it's not flowing from one ventricle to the next as it should. So this is going to be obstructive, right? It just means that, okay, here's one ventricle and here's my other ventricle, and I should just have a natural flow, but there's some big thing pressing on this that's making it difficult for the fluid to move from the first to the second. Communicating is, okay, between the ventricles, the CSF is flowing completely fine, right? It's not obstructive, but for whatever reason, it's not being properly absorbed by the veins, and then exiting the head. Third is we have normal pressure. So here you have an increased CSF, but for whatever reason, your pressure is more or less the same. And this might be because of like a Boyle's law thing. So if you have like more CSF over time, the increased pressure kind of stretches out the ventricles. And if the ventricles stretch and they're squishy and compliant, this means that the pressure is going to go down a little bit. It actually turns out that the pressure might sometimes be elevated in normal pressure, but it's just kind of sporadic, and so you have to check it at the right time, which might be difficult. And then our fourth one is ex vacuo. This one's really just a phony, right? So these are just the large ventricles, but not because of extra CSF, and there's not extra pressure either. It's because of brain atrophy. It's sort of just, maybe they're expanding a little bit, but it's mostly just that they look bigger relative to the fact that the rest of the cortex is getting smaller. So non-communicating obstructive hydrocephalus is usually congenital, something like a Chiari2. It could be Chiari1, Chiari type 2 is a little bit more significant. Dandy Walker shown here, Chiari type 2 shown there. And this pressure in the cerebellar region is pushing on the aqueduct of Sylvius and the fourth ventricle and obstructing the flow down into the fourth ventricle and the foramen of Magendie or Luschka, the median and lateral apertures, which is then going to push it into the subarachnoid space up to the brain, where it can empty into the veins. With this, you get sunset eyes. So remember that if you compress the dorsal midbrain, you get Collier sign, which is kind of the opposite of ptosis. The parasympathetic fibers going to the levator palpebrae are inhibited, and so there's this lid retraction where the lids are super open, and then vertical gaze palsy for whatever weird reason that I don't understand. And so there's these eyes are kind of downward facing, and they're called sunset eyes. They kind of look like a little sunset. Communicating, this is non-obstructive. So why would we not be able to drain from the CSF and the subarachnoid space to the veins? Maybe we had meningitis, an infection in the meninges, and it damaged all of these structures. So it damaged the granulations, and now they just, we had a subarachnoid hemorrhage or something, and now it just doesn't drain properly. Normal pressure, so as people get older, this is actually pretty common. So this is just for whatever reason, there's an elevation in the CSF. Maybe in some old people more than others. And again, the ventricles are going to kind of expand and accommodate this so that the pressure doesn't go up that much. And if it does, it's sporadic, so it's hard to check. Technically, this is a communicating hydrocephalus. I just don't like to categorize it. And then the clinical presentation is very different than the other communicating hydrocephalus. So I just think of this as separate. This is normal pressure hydrocephalus. I think of this is for old people, and old people have trouble with the internet, like websites, like the World Wide Web, www. So this is wet. So they have bladder incontinence. Wobbly, they have this magnetic gait you can see here. And then wacky, this might also cause dementia. So this is again sort of fake. So actually we see these two things. Here's the ventricles and here's the brain. One of these, it looks like the ventricles are getting way bigger. But actually, mostly what the animation is doing here is the brain parenchyma is getting much smaller, and then it's resetting. And it's just kind of to show you that, like, because one's getting smaller, it just makes it look like the other one's getting bigger. So people with neurodegenerative diseases, traumatic brain injuries, CTE, and schizophrenia, they're going to have extra atrophy of their brain tissue. So let's contrast this. This is someone with normal pressure or hydrocephalus. So as you get older, you're going to have cortex atrophy, but maybe even a little bit more in NPH. But contrast that with someone with hydrocephalus ex vacuo, maybe someone who has like severe dementia. Notice how thin and frail the cortex is. And it just makes these ventricles look large in comparison, at least to like a normal person. And again, maybe they're getting a little bit bigger, but I would say it's mostly just that the surrounding area is degrading, and so they're just kind of like filling in that space and look bigger by contrast. Better way to think about these, in my opinion, is congenital hydrocephalus. So this is the obstructive one. This is Chiari or Dandy. Could be a tumor, and you get this Collier's sign and the sunset eyes, and just a huge increase in intracranial pressure. And then you could have acquired. Maybe you get meningitis. Maybe you have like a stroke of the subarachnoid aneurysm, and this just damages the arachnoid granulation, so you cannot drain your CSF into the veins. Also is going to increase the intracranial pressure. And then normal pressure, as the name says, does not really increase the intracranial pressure. Maybe there's a mild increase. Maybe it's fickle. It depends exactly when you measure it. And it's just from getting old for the most part. And I think of old people having trouble with the World Wide Web, wet, urinary incontinence, wacky, dementia, and wobbly. They have this kind of magnetic gait. And ex vacuo doesn't even really belong here, in my opinion. So it just doesn't even increase the intracranial pressure. So this is our silly little segue to tumors. So TBIs, hemorrhagic strokes, and now also brain tumors can also increase intracranial pressure. So let's talk about them.